So our next presentation is from Susan Morris Wilson, who serves on the Planning Council, who has had a great career in terms of health and human services management and leadership and advocacy. I met Susan last fall, and she's been a real partner in this, so I want to thank her for all her work around this. And also with Linda Dickerson, who serves as the research analyst for the Mental Health Planning Council.
So good morning. We're ready to keep on going here. My name is Susan Wilson. I'm on the Planning Council, and I'm sharing my presentation today with Linda Dickerson, who will be up here in a few minutes. Linda, Jane Adcock, and I, along with many other people, have made this effort to do the data notebook. And I want you to know that this data notebook is not just a frivolous thing that came out of our imaginations. This is really supposed to be a good and useful document. You've heard a lot about data this morning. You're going to need to use that knowledge that you learned about data this morning as we walk through our data notebook. Linda's going to do the very specifics, so the reason that you each have a data notebook in front of you is so that you can go through the data notebook question by question with us, okay? And that you can take that information back. And we think that this is a good way to use the knowledge that Cricket gave you a little earlier. Our purposes here were to provide a structured format and questions that would assist local mental health boards to review and report on data from their counties. And you know that that's a mandated role for local mental health boards. We hope that this will also provide you with some guidance and give you an overview about how to use data. Finally, this data notebook is really important to the Planning Council because we need data from local mental health boards in order to make our report to the legislature. So you're helping us fulfill our role as well. I think we have, I put the wrong slide set in here. But that being beside the point, I can move along. Just ignore the slides. So I want to talk about how we came up with the data notebook this year. We worked with the CALM board, and we worked with the California Planning Council members. We spent a lot of time looking at our last data notebook. Now, how many of you were involved with the last data notebook? There's at least a few of you that I see in this room. And were there problems with the last notebook, which we called the workbook? We changed the name so you wouldn't think about it as negatively this year as you did last time. There were many problems with our last one. It was the first attempt we had ever made. And some of the problems that we ran into were old data. And you heard Cricket talking about data. Data needs to be relatively current. Is it appropriate, for example, for us to make decisions on data that's 5 to 10 years old? Sometimes, but not always, right? Sometimes that data might be okay, but generally, especially in the changing world that we have in mental health today, we want the data to be the most current that we can have it. We did limited training last time, and this time we're hoping to do more training on the data notebook. You're kind of our experiment in training right now. Last time the notebook or the workbook had limited applicability. So we asked questions last time mostly about access and penetration, which are good questions, but then what could you do with that information once you had gathered it, once you had talked about it, and so on? Did you actually use it to inform your decision making? Did you actually use it to talk to your stakeholders? Did you actually use it to approach your board of supervisors? You know, and it's our feeling that since only 17 of our last workbooks out of 58 were completed, that not many people completed them and not many people used them to inform their decision making. So we're looking at that this time to do things a little bit differently. One of the things that we know is the Welfare and Institutions Code, Section 5604, and those of you who are on the COM board, I saw you passing out copies of that yesterday. One of the things that we know is that you have some very specific requirements about reporting to your local county, correct? Yes? So just a quick shout out. What are some of the ways that you do it? LA, what's a way that you do it, Larry?
Our meetings following our town board meeting, we give a report as to the major issues.
Okay, so you report those issues back, right? And I forgot that we're recording, so I can't really do shout outs because nobody can hear you then when we have the recording. But basically, we want comm boards to be aware of their requirements, and so that will be part of our training. And we want them then to take that information that they collect and become good advocates with it. One of the things that I do want to tell you or talk about just briefly, I apologize for the slide set. I don't know how we ended up with the wrong set today, my fault. One of the things that we want, and we're going to talk about this afternoon, is as we evolve this data notebook project, this is the first of an annual project, we hope. So when I was talking to the comm board yesterday, those of you who were there heard me say, we want you to really use this one and then come back to us again, as you have in the past, with constructive ideas about how do we make this better, how do we make this useful to you. You know, we want you locally to think, what programs do I have and what kinds of things do we need to improve? How do we improve the quality and services in our community? We want you to think about the data that you collect. We want you to think about the data that you're using locally. And so some very specific questions I want you to think about that augment the ones that Cricket talked about are, is our local data accurate? You know, and remember the first five, pictures and numbers need to match. Pictures and numbers need to match. So sometimes you know the story and somebody presents you with numbers and you have to say to yourself, these two things are not matching, you know. So your data needs to be accurate, your data needs to be current, your data needs to be pertinent. One of the things that I see is people collect data about stuff that they don't really actually want to know the answers to. So you need to think about data in terms of what do I want the answers to? It needs to be consistent over time. In other words, if you collect data today about access and penetration, you want to collect it over time so that you can see the trends, right? If you collect data on access and penetration, let's say in the Superior region, you want to collect kind of the same type of data across the counties. So different counties today collect different data, and then we try to compare them, and that's the apples and oranges stories. As you listen to Linda today, who's going to go next, think about how and who you will use to help you with your data story. Because how many of you in here are research scientists? Do we have any other? Not very many. So what we want you to do is figure out who on the mental health staff, some of you actually have a QI coordinator, a quality review person, some of you don't. I'm looking down at San Diego, Orange, those are two counties that do have staff that do it. LA has staff that does it. I have to say in Shasta County where I come from, we have like a 25% or 25.25 FTE, so we have a quarter of a person that does this. She is not trained to do it, and I don't know who's doing it today, but when I was the chair of the board, she didn't like the job very much either. And so you need to figure out who are those valuable people to go to locally, and we're going to talk about that a little more this afternoon. So with that, I'm going to hand it over to Linda, and she's going to talk to you about our very specific data notebook. So get it out.
Well, good morning. I'm very glad to be here with my colleagues, and I hope that what we present today will be very helpful to you. What we've tried to do is focus on the most essential questions that we could find, and there were we had many, many more questions than appear in your present versions of the data notebook. We've simplified it because we want it to be something that everyone can use and everyone can work with, regardless of whether you're a small county or a large county. And so I'm going to review our major questions. I'm not necessarily going to address every single question, but there's going to be a few highlights where I'll try to address how to answer the questions and what are the sources of data and info available specific to the data notebook questions. We provide you some of the data. Some of the data you will need to find from your local county, either your quality improvement coordinator or your director of mental health or behavioral health. And the other thing is that we're really asking a number of questions that are about your opinions and experiences or your assessment of what's going on in your local community. Those are lived experience, those are subjective questions or information, but they're also very important. They serve a role very much like stakeholder input, assessment of needs, gaps, what are unmet needs, what are some of the strengths that you can think about in your community. And we're very appreciative of having data from the EQRO that we've included. We've included three major sections of data from the EQRO figures and graphs. And it's a sample of some of the other types of data that you can find in your EQRO report should you choose to look in it. So please locate, if you have it, your county data notebook report, and we'll go from there. As has been noted, we don't have them for every single county. I've tried to make as many as possible. There were some that I made that apparently did not make it into the packet for shipping, but we can arrange to get those to you otherwise, either by email or snail mail. The first thing I want to direct your attention to is the page that starts out with instructions. And it tells you some information about how to fill it in. We're asking that this be a project that the mental health board members or commission members fill out themselves. You are the most important resource for identifying program strengths and needs in your community. And then on the first page, we're asking you for some information about your county. There's a data page that follows this. We're asking you, what is the website for your Department of Behavioral Health and Mental Health? And if there is a website that posts public reports about your county's mental health services. Some counties do some very, very good public reports. And I only know of a few of them. There are probably a lot more out there, but they're just not well publicized. Monterey County, Humboldt County, San Mateo County, I think San Diego County's done some reports, and Alameda County as well. And I've just come across this last week some reports out of Solano County, where I live. And they can be short info briefs, or they can be longer, more detailed reports, and every county can do it a little differently. But that's something that will help all of us know a lot more about your county. So I also include mailing instructions for how you can send your filled-in report to us at the Planning Council. You can do it two ways. You can email it, and we even have a special email address set up for this project. It's datanotebook@cmhpc.ca.gov. You'll see that there at the bottom of the slide, and it's on this informational page, and it's also on the very last page of the document where we say, reminder, please send it to us. Or, so that would be one way you could send it, either as a Word attachment or as a PDF if you wish to do that, or you can send us a paper copy, or and the mailing address is also included. So this is really important. We really want to get reports back. Yes?
Is this listed on the EQRO EQRO board website, you can go in there and
You
pull
can-
up all the counties, and they'll give you a report with all this.
The EQRO website does not have the data notebook, but it has EQRO reports for your county for the current year and the previous year. And that's where we're getting some of our data. So the data notebook presently is not appearing on any website. Whether we have plans to post it, I don't know yet. So. I'm sorry, I can't really. Okay, this is an excerpt of the data that comes to your county, that your mental health director, and he has a sample of the data pack that the mental health director gets from the EQRO before their review, and it appears that someone has shared that with you, either your county people or somewhere else. And I see a question, if someone can.
I still don't understand why the city of Berkeley has been exempted.
We don't have any data for you. We don't know anything about your data. Nobody reports it to us.
That's why I don't understand if the city of Berkeley has an independent mental health division, why are they not bound as the other?
I think you have
I can answer. I'm a Berkeley resident, among other things. Berkeley data appears in the Alameda County data.
Okay, but is it distinguished as being separate from Berkeley?
No, it's not.
And I'm not sure.
But you can, we don't have separate Berkeley data. We don't have separate Berkeley data in the same sense as we have Alameda data. However, we do have data that drills down to those programs that are operated by Berkeley. And that's the same thing for the other one is Tri-Cities, which is really confusing. And the reason it exists as a separate entity is historical reason. When the my understanding, when the Short Oil Act was developed, there were a couple of entities that had their own health departments that were smaller than counties, Berkeley being one, another being Tri-County, which is in Pomona area.
I understand that, but I don't want to take up too much of your time, but even though if we're a separate independent mental health division, it seems as if we should have the same obligations as everybody else.
You're actually not separate in the same, there's only one mental health plan for Alameda County, and that's the Alameda County Mental Health Plan. That's what the EQR, you'll see, the reason we exist is to review mental health plans. But yes, we have done focus groups in Berkeley, we've reviewed the programs, and the data has been included in our Alameda County report.
Yeah. Thank
you, Carol.
I think the other part of that answer is that the contract with DHCS for EQRO to do the reports is to only do the county MHP plans and not produce a separate report. So I think would that be correct? That the contract is only to do the counties. And now if your local people have information for you, then that's a separate issue that you would need to address with them. So the other part on the data information page or county information page, besides asking you for information about your county websites and any public reports that they post that are summary reports about any of their programs, we really would like to see some way of tracking down some of that, because it's really, every county does it differently and it's very disorganized trying to locate all that information. But we'd like to know more. We'd like to share information about successful programs that other people can learn from. And it also helps us with our statewide reporting as well, and helps consumers and family members. So the other thing that's on your county information page, this is data that I have located, some of which comes from just public statistics. What's your county population? You may know that you're kind of big or kind of small, but not exactly know. So if we are looking at numerical data later in the report and something says, oh, we got 45 of these, well, if you're in a small county, maybe that's a lot. I mean, the really small rural counties. But if that's LA County or Orange County, maybe 45 is kind of a small number. So the numbers have to have context. And this one here, what I'm showing is Monterey County, and I've provided the total number of populations who received Medi-Cal in your county in the most recent year, the average number of Medi-Cal eligible persons per month. And that's different because a lot of people go on and off the program, and the most stable number to look at is the average per month. And then if you go down a little further, you see total persons with, I've used abbreviations here, SMI or SED, serious mental illness or serious emotional distress, which is the designation for children and youth who received specialty mental health services. So in this county, it was 4,556. But in each of these groupings, I've tried to present what's the percentage of children from ages 0 to 17? What's the percentage of adults who were either eligible or who received services? And in some counties, you have very high numbers of children. And in some counties where the population is aging, you have more adults ages 60 and over. And so there's a tremendous variety in the counties. But this is to give you context for your county. So this is part of the customized data that I put into each report. Okay, we have a question here from the gentleman in the yellow shirt.
Should we wait until the fiscal year is over?
This data is for the most recent completed year that has evaluated data. So this is calendar, in this case, it's calendar year 2012. We won't have comprehensive data for 2013 for quite a while. So that's the most recent year. And in terms of state processes and state data, I am told that is lickety-split fast. So as I came into state service and kept finding stuff that was more than 3 or 4 years old, and I was very frustrated. So if you're getting this data, this is the most recent that we have for specialty mental health and Medi-Cal-based data. Okay.
So are you wanting us to collect 2013 data since you have 2012? Or are you expecting
No,
us
this
to-
is just for you to look at. This is to help you understand the nature of your county. Now, some of these numbers will not change greatly from one year to the next. They will be very similar, except this coming year, because we have the Medi-Cal expansion population. So that's going to make a big difference. And we're all waiting to see exactly what's going to happen. Certainly, Department of Healthcare Services has made projections, but nobody knows until we get the actual information. Okay, another question.
I'm still confused. When we complete this, the data you're looking for is from what year?
We're looking for the most recent year that's available. If you have most of the data that you will find in there that we provide is the most recent that we could find. And some of that has to do with the review cycle. For example, they can't prepare reports on every county instantaneously. They have to divide them up over approximately 10 or 11 months of the year. And so the data, for example, for Los Angeles County, the largest county, are lagging by a year because their current review either has not been done or it's just been done, and the report's not ready for us. If they get it and they want to incorporate that instead of what we provided, which is actually the preceding year, that's great. If they want to substitute it, that would be great. They're not required to do that, but if they want to, they can. Okay.
And for the sections where they need to ask their county mental health director, what year should they do?
The most recent that is available. They can't give data that aren't available.
And I'd like to suggest that we hold the questions because Linda actually has quite a long presentation and she has about a half an hour to finish it. So if we could hold these questions, we're going to have plenty of time later. Let's let her get through her presentation.
Okay, so the first major question, if you'll turn to that page, it says integrated health, treating the whole person. Our goal there is looking at the goal of integrating behavioral and physical health care, linking clients to primary health care. And our question is asking more about processes and programs. And this is also an opportunity for counties to tell you about some of their successes, because what I'm hearing, sort of a back channel at least, is that the data for many of the full service partnership clients and for many children and youth is that they're really making good progress and making sure that their clients are getting linked to primary health care, whether that's a physician or a nurse practitioner or whatever. So we're asking you, if your county has numbers where they can say, or a percent where they can say, this many got linked to primary care and saw a physician in the last year, or the most recent year that they've taken data, that's great. Not every county is moving forward at the same rate. If those numbers aren't available, then just go on and describe any efforts in your county to improve the physical health of clients. How are they implementing this goal? This is what that is about. What are the steps they are actually taking? It might be case management, it might be referral processes, it's any number of things that it could be going on. The second question is about wellness programs. What about various types of activities and skills? And this is about mental health clients and families learning to improve their own health and taking charge of their own health to the extent that they are able. And so we ask the question in a sort of general way, how does your county address wellness programs? And I list a number of programs. But there may be other types of programs. These are just some ideas to start the discussion. Because, as I say, things are happening at different rates in different counties. And in a small county, maybe the best they can do, besides getting you linked up with your primary care person, is maybe running a flu shot clinic or something in the fall, or getting people linked with a walking program or stop smoking, or something like that. It's going to vary greatly. And so this is what I think is one of the most important questions, because as we know, individuals with serious mental illness over their lifetime, their lifespans tend to be 25 years less, typically, than other persons in the community. And what they're dying of, aside, I mean, you might say, well, okay, maybe some are committing suicide or having accidents, but what is costing years of lives are the things that kill us all, and that are like heart disease, high blood pressure, diabetes, cancer, and diseases related to smoking, and things that are where good preventive care would make a difference. So those are really key. This is something I think both Susan and I feel a strong sense of mission about. So we're going on to another question, and this one is a question about access. How many new mental health clients? We're asking, how does your county define new client for those individuals who might previously have received services but who have not received services for a while? And then please provide data your county has on the number of new clients last year. If you have it, how many were brand new clients? Sometimes that number is hard to get from the data systems because you have to figure out, is this client a duplicate of another client with a similar name and almost the same date of birth and a similar client identification number, but there's just a lot of typos in the data set. So that takes a lot of programming to sort out, and it's not always simple. So if your county doesn't have the data, just tell us what you do have. You may not have perfect data, but just give us what is available and tell us what it's about. And Susan had some comments about this whole definition about new clients and closing cases and
It appears as we look at data that comes from local counties that different counties define new clients differently. So one of the things we want you to do is think about the period of services that a client gets. When do you close a case? When do you reopen a case? Because there's a lot of closing and reopening cases in the mental health departments. So how do you, what is your definition for reopening a case, and what is your definition for a brand new client is a brand new client? We're really after brand new clients.
Mm-hmm. Okay.
People you have not seen before in your county.
Okay. Good clarification. Okay, so we're going on to the next major area of focus here, and that is it's about outpatient appointments after discharge, follow-up after people have had a mental health hospitalization. This is actually a national quality measure for all types of hospitalization, whether it's someone was in the hospital for heart disease or diabetes. The Centers for Medicare and Medicaid are very upset when people maybe have not gotten adequate follow-up, or if something was not adequately treated in the hospital, and suddenly they're back in for a related condition or something they should have caught while they were in the hospital. So what we're looking for here is the mental health equivalent of that. It's about mental health hospitalization. This data is only about Medi-Cal-based mental health hospitalization that we have gotten from the EQRO. If your county has more comprehensive data, you're welcome to supply it where it's other types of hospitalization besides this. So what we are looking at is, do people get their outpatient services within 7 days of being discharged, or is it close, or is it within 30 days? What percent? So we're comparing here. Let's see if I can make the pointer work. Okay, so the blue bars are the statewide bars, what the statewide averages are, and this happens to be, I think, Sonoma County, and for the year before this, and they were able to provide outpatient services to 55% of their clients within 7 days after discharge, and those that were readmitted to inpatient status were only 6%. And then looking at the within 30 days measure, then statewide it was 60%, but this county did 69%. So they were exceeding the statewide averages in terms of good follow-up as soon as possible. And their overall readmission to inpatient level was 10%, which is much lower than the statewide average. So now for smaller counties, it only takes 1 or 2 people to refuse any follow-up to throw off your statistics. So do try to understand the dynamics that are going on locally. So the thing is, well, this is what happened one year. What about if you're trying to evaluate it? You look at the chart and you ask, is your county doing better or worse than the state? Try to discuss why. Does your county have programming available that specifically ensures a warm handoff for follow-up services? And do you have any suggestions on how your county can improve that follow-up and reduce re-hospitalizations? The idea is to help people stabilize and get on the road to meaningful recovery as soon as possible. One of the interesting So here we have, this is a county, this is Monterey County, and now we have 2 years of data. So we have more bars to look at. But keep in mind, the blue is the statewide data, the red is the local county. And so you've got calendar year 2011, calendar year 2012, and it looks like for Monterey County, they're increasing their percentages of follow-up. Their levels of rehospitalizations are staying a little bit flat and very similar to statewide averages. Then within the 30-day follow-up, they're doing about the same as the statewide average and not seeing so much change in their readmission rate, but it's tending to be right around the state level. So you have to evaluate what does that mean for your county. For the really large counties, your averages are going to be very close to the statewide averages just because a kind of law of large numbers. It's the large counties that drive the statewide averages. So, so the other thing that is perhaps worth knowing is that those counties that particularly make a point of following up with medication services very early on have a little bit better success rate in reducing rehospitalization. That seems to be the most important service for people to get within 7 days, based on analysis of the statewide data. So we move from hospitalization and follow-up to another kind of question. Another kind of question about barriers to access. This is, again, a subjective question. It's something that you evaluate what's going on in your county. The barriers to access in the rural northern counties, they include things like long distances and having to drive sometimes anywhere from 50 to 150 miles to get to services. In an urban area, you may be taking 3 buses and bringing your toddler and older child along in tow. Now that's a really challenging. Those are all kinds of barriers. Other issues, depending where you're at, there's language barriers, lack of people who are truly bilingual or bicultural, too few child or adult therapists. And one that I heard from one of the southern counties was a restrictive time window to schedule an appointment. I guess it was something like 2 hours every Monday, and that was the only time that you could schedule an appointment. So that seems a little bit of that seems like a considerable barrier to me. But this is something where you evaluate in your county. What are the most significant for your community? And this is another question designed to facilitate your discussion about what are the barriers and what might be done to overcome some of those. So the next area that we look at here is fairness and access by unserved and underserved communities. Now there are several ways to look at this kind of issue. One is to look at service penetration rates, which some of you have seen before as members of the board or that you may see from your counties. But what we're trying to do here is to take a more qualitative look and let you just look here at the percentage of the overall pie in terms of who's eligible because they're on Medi-Cal and who receives services. This one is Monterey as an example. And if you look at the pie chart on the left, you see this big red chunk that's about almost 80% Hispanic eligibles, but just a little bit over half of the people who receive services are Hispanic. And you can go and compare each of these different race ethnicity groups. And some counties may do a more detailed survey about subpopulations within those groups for their own needs. And just sort of as a matter of eye training, you can see, here's the statewide numbers. The top left one shows the statewide eligibles, those who are on Medi-Cal. And the one over here, this shows statewide numbers for beneficiaries served. And then down here, just as a contrasting example, I believe this is Sonoma County for 1 year. And these were the Medi-Cal eligibles and the people who received services. So every county is very different. We have a rich variety in our state. And this is an example where I've prepared customized data for each data notebook. So the questions based on that are the following. Is there a big difference in the race ethnicity breakdown on the two charts? Do you feel that the groups that need services in your county are receiving services? What outreach efforts are being made to reach minority groups in your community? Now, this might be a question you can talk with your mental health director or QI coordinator about, and they will tell you something about specific programs. There is also some information in your EQRO reports that addresses these kinds of issues. It's a kind of narrative or descriptive discussion about some of those efforts, whether they've tried to hire new people or whether they have instituted parenting classes in Spanish to reach out to the Hispanic population, or special programs to reach out to transition age youth and so forth. And then again, this is where we're asking for your opinion, because change only comes about when we start thinking about, well, what could we do to make things better? How can we help the people who are not getting helped? What are the specific needs of our community? So what are your suggestions? And this is very important. You may even hear from your mental health director that there are programs that they want to do but don't have the funds or capacity at the moment. So that's another area of potential information. So we go on to something where in the next major heading in your notebook, it's about client engagement and services. And we're using a kind of a substitute. Engagement in services is a very difficult thing to measure precisely, but we use given the kind of data sets that we have. So what we do is look at something called retention rate. And this is where we look at how many services did people receive over the last year. So this is an example from Monterey County. The way that if I were in this county, what I would be looking at is I would say, how many people got 5 or more services? Some people say, well, that's a kind of minimally adequate number. Now, it's not an optimal number necessarily, but that would give you appointments for an assessment, maybe a medication review and prescription, maybe some case management, maybe you had some crisis residential treatment or crisis intervention service, or maybe you met a therapist. That's not very much. That's sort of a barely keep you afloat and not drowning. So that's why, this is a very debatable question, in terms of where do you draw the line at these numbers? What do they really mean? So 5 to 15, the number of people here who got that many services was 28%. 28%. How many got more than 15 services? That sounds like maybe they got a chance to meet with a therapist at least once a month and got an assessment and some prescriptions or prescription review. or something like that. And so here, if you add these two numbers up, the 28 and the 47, that's looking like, am I reading this right? 3 and 4, about 75%. So they're doing, actually, by the measures that we use, they're doing pretty well. But then the other question you can ask in your county is to think about, what about the numbers who only came in for 1 or 2 or 3 services? Is there some reason that they did not come back for more services? Was there some reason that we should look at? Is there, you know, maybe when they were assessed, they really felt, well, okay, they didn't meet the criteria for needing the kind of services that the county would provide for the most seriously mentally ill individuals. So those are questions that are, those are things where we can't really tell you what the numbers mean precisely. That's a discussion you need to have with your county people. So, and here's a separate, another example where they present, I only provide you data for the overall population, but you can locate data for transition age youth and foster youth as well, if those are particular areas of concern. So we would have to say, what are the questions we would like you to address? Do you think your county is doing a good job at keeping clients engaged in services? If yes, how? If not, why? And what is your county doing to follow up and re-engage those individuals who may need further mental health services? And the other thing is, we can follow up on this concept of, what about your county's engagement of traditionally underserved communities? So we come to the last major group of questions, and this is, we've picked one client outcomes question from the Consumer Perception Survey, and the data were analyzed by Stephanie Oprendak at CiMH, who kindly provided us with the data. And so what we have here, this is the information that you can see here is for adults over 18. How did people respond to the question? As a direct result of services I received, I deal more effectively with daily problems. So we have strongly disagree, neutral. So, okay, those are 3 categories where people felt they weren't helped. Agree, strongly agree. So we see also that in this county, the total number of responses they received to this question was 205, which seems pretty good considering the size of the county. And then, and it looks like 30 plus 41, so it looks like 71 or to 72% felt that they benefited from services. So this is really not a question about satisfaction. This is a question about effectiveness. Do they perceive that their services were effective? Which is a very different thing. You might like the people you see, you might like the therapist, but maybe you're not getting better. That's the difference between satisfaction and effectiveness. So then down here, we have the similar question for children and youth under 18. As a result of services my child and our family received, my child is better at handling daily life. So again, we have the same categories, the 2 that disagree, the neutral, the agree and strongly agree, and we had a total number of responses for children and youth of 242.
Just wondering why there doesn't seem to be any comparison with statewide figures on this one where there are on all the other areas.
Okay, because this is the data that I entered into your this comes from a different source. This did not come from EQRO. This is data from CiMH, and I've entered it into this, typed it individually into every single table. And if you want to see statewide, or if you, that would be something that we could provide to you. We could add that information.
I think that's a good suggestion, Richard.
Yeah, and the question is, do we want to see statewide, or do we want to see data for, if you're a small county, do you want to see the summary data for all the small counties? Or if you're a medium-sized county, do you want to see medium-sized county data? Or do you want to see statewide? Well, it's going to give you lots and lots of columns of numbers. What's going to be the most useful? You're saying both, but if you think about
if all the other stuff is statewide.
yeah. I mean, I guess we could provide the tables. We have them. It's just a matter of, I wanted to be sure to not overwhelm people and confuse them. So, and I see Carol has a question.
How were the surveys distributed, and how did you reach persons who are less likely to respond to surveys in writing?
I think I'm going to direct that question to Susan, as she's more familiar with county operations.
Well, I'm not sure about that, but I think CiMH should. That's what I was doing, was coming this way.
You're in luck. Stephanie Operndeck is actually retiring, and I'm taking over the statewide management of the Consumer Perception Survey. So California's participation in, we just looked it up because I couldn't remember, MISIP. MISIP stands for Mental Health Statistics Improvement Program, and it's federal mandates to assess client satisfaction with services. The data that we got, let's see, this past year, things have recently changed. I think we're doing it twice a year now. But the assessment is what we call a point-in-time assessment. So all county mental health providers have a 2-week window in which they're supposed to ask every client who comes in for services within that 2 weeks to fill out these questionnaires. And they're fairly long questionnaires. They ask information about satisfaction with services across a variety of domains. They're available on CiMH's website. If you can't find them, just send me, shoot me an email and I'll send you a link. They're available in multiple languages. And the response rate that we got across counties, there were more than, I think we've got about 40 or 50,000 records just from those 2-week period of times. And we can answer specific questions about response rates by county, et cetera. I think the manner in which they're distributed within each county is likely going to vary. But the idea is that all clients receiving services within a 2-week time period are given the opportunity to fill out these questionnaires. Yes. Thank you. The data that you're looking at here was from an assessment conducted in August of 2013.
I want you to remember that each county sets up their own method of doing the consumer perception survey. So, for example, we heard from Monterey that Karen Hart stood in the lobby of the Monterey mental health, different places, and handed them the survey, helped people complete the survey. I know in Shasta County, it's my understanding that last time we just left the pile of surveys sitting on a table in the middle of the room. This is not a good way to collect consumer perception surveys. You know, so one of the reasons that we did put this data in our notebook is we want you as a local mental health board to say to your director, hey, when do we collect those surveys? Hey, how do we do that? Hey, you know, and really address some of the issues, Carol, that you bring up.
Okay.
Kings County, we're doing ours like next week because we had to staple them all together and everything. But we have peer specialists that sit down and help them fill it out. We have a room and everything, and it's just
Perfect.
It works out perfect.
And you provide them with some privacy, because does everybody want to answer that question sitting in the middle of a room with 22 other people in there? You know, these are really good questions for you to address. And I have to say, and Jane and I struggled over this when we were coming down with the final questions, how do you really measure effectiveness in terms of clients or consumers? And they're the only people really that can do that. So this is a really important piece. It's an important survey, and it's one that I think doesn't always get the attention that it needs. San Bernardino, you had a question? Did you have a question?
Well, I was just concerned about the reliability and validity of the data, given whether or not your helpers are trained, etc.
I was going to address that also. So I managed in Contra Costa County for several years, and we would hire from a consumer-run organization, we would hire and train consumers to do the survey, and that's exactly it. You need to train and get the same information, just like Cricket was saying earlier. How we say how you should ask these questions is just as important, and so that's a really important part of it. You can't just give, even if people who are staff, no matter what their position, or volunteers, you have to say, this is how we'd like you to ask the questions, and this is why we need this information. So that's really important.
So this goes back to the consistency that we were talking about so quickly, because we still need to finish, and I'm sure you all would like to eat lunch today.
Right.
We'll do David, John, and then back to you, Carol.
Great.
There's on a couple of these charts, there's an abbreviation representing our county data, MHP. What does that stand for?
That's in my talk this afternoon.
It stands for Mental Health Plan, and
Okay.
each county operates their own mental health plan.
Thank you.
So it means your county's.
Okay, quickly, John.
Yeah, my question and comment was that I would actually like the data on who fills out the surveys, actually.
You mean demographics? Well, the problem.
No, actually,
Yeah.
well, that's
Yeah.
part of it. I'm sorry
Like
to
age
cut
and
you off.
race, ethnicity.
Yeah,
all
well,
that.
in our county, we had different places. We're very customer service orientated, and we wanted to make sure we were getting it from. And so we realized that over a couple of years, we were sort of getting the same core group of people that were always filling out the surveys.
That's called oversampling.
So we went about trying to find other ways to incentivize and to seek out people that normally might not, and what the barriers to filling out these surveys are. And we've had some luck with that. We offer some snacks to some people when we do certain things, and if they fill it out, we do a little gift card thing. There's a couple different things that we do to make sure that we're getting it from outside, and especially the underserved populations, because we want to make sure that it's reflecting the community as a whole, and it's very important to do that.
Yeah, I'd like to say that those kinds of comments and discussions are the kinds of things that you can put in your data notebook as you discuss the questions that we raise, or in terms of the suggestions that you have, what has worked to increase your response rate. Those are things that you can use to answer this, that say, this is what we've done that's been improving things, these are things that we think we should do. And you have kind of a free answer here in that, to part of this, of what are some suggestions. One is to increase having peers that you pay, or volunteers, peer support staff, that help. So that's like a free answer that you can all scribble down if you feel it's appropriate.
Okay, just quickly, because your lunch is ready, we're going to hold the rest of the questions, Carol, Dolores, until this afternoon. Let Linda, we'll give you a couple minutes, Linda, and you can wrap up your presentation.
Okay, so lastly, and perhaps most important, with respect to delivery of services, do you have suggestions regarding specific unmet needs or gaps in services? This could apply to any kind of group in your community. It could be veterans' mental health. It could be released offenders. It could be any number of things. Improvements to or better coordination of existing services, new programs that you think need to be implemented to serve individuals in your county. That's a pretty key thing. And I'm going to ask, let's see, the final question or comment that I have is, are local boards permitted to provide additional information besides what we request? You can send us whatever extra information you want. We welcome it. I welcome it. We will try to incorporate as much of that in our final reports, especially if you have successful programs that you would like to kind of showcase about your county. That's great. Anything extra, they're not required, but they're welcome. You can send them as attached as an appendix. And if there's a website where your county publishes some great reports, that's another one. But note, they are not required. And the other thing is that in law, it's not required for like Berkeley City or Tri-Cities to submit reports. But if you want to use the data notebook process, we welcome whatever data you're able to locate and provide as to add to the statewide discussion.
And what we can do is provide you with a sort of I'll call it, for lack of a better word, a naked notebook, an unfilled notebook, but we will give you the notebook for the county that your space is in.
And,
Great.
And this is my final plea to remember to submit us your data reports. And you can either email them or you can send them by regular postal mail.
We haven't got a target date yet, but we're going to have one very, very soon.
Yeah.
Great.
I think by June 30th is what we're aiming for, just to give you all a heads up. June 30th?
So we're
July
going to
30th.
just stop for now. Thank you very much, Linda. Very informative. Thank you, Susan.